Well, good evening, everybody, and welcome to this Catholic Union webinar with Dr. Dermot Kearney. It's a pleasure to have you all here. Before I introduce Dr. Kearney, I'm just going to tell you a little bit about the Catholic Union for anybody who's taking part in this webinar that doesn't know us. Catholic Union is an organization of lay Catholics engaged in politics and public life. We invite membership from all lay Catholics in Great Britain. We work with Catholic politicians, Bishops' Conference and other Catholic organizations to put forward the Catholic viewpoints in politics and public affairs. We follow legislation in Parliament. We make representations on draft legislation or on government policy. We respond to consultations and we organize public lectures like this, usually before COVID in person, but now a mixture of in-person and online events. This is our first webinar of the year, and I'm absolutely delighted to welcome Dr. Dermot Kearney. I'm going to let him introduce himself to some extent, but just to say that he is a consultant cardiologist. He was formerly the president of the Catholic Medical Association, and his Twitter description includes Irish exile in England. Some of you may well know Dr. Kearney from events in the last year or so, but others may not. So I'm going to hand over to Dr. Kearney and ask him to tell us about his work in the abortion reversal process. Before I do that, if you have questions at any point, as I'm sure you know, there's a Q&A function on webinar. If you could put your questions in the Q&A, preferably Q&A rather than the chat, that would be helpful. And after he has spoken, he's kindly agreed to answer any questions. So without further ado, I'd like to hand over to Dr. Dermot Kearney. Thank you.
Thank you, Nigel. And thank you, everybody, for joining us this evening. As Nigel said, I'm working as a cardiologist and also I suppose a general physician, and that's important. One of the allegations against me was that I was working outside my specialty, and we'll talk a little bit more about that. So I tried to emphasize as much as I could to our opponents that I wasn't just a cardiologist. I have a little bit of knowledge of other areas of medicine as well. I trained in Ireland. I qualified in 1989 from UCD. And after doing my sort of specialist training in cardiology and general medicine in Ireland, spent 2 years in the Netherlands, working in Leiden and Amsterdam and doing a fellowship in interventional cardiology before taking up a post in the northeast of England at the Queen Elizabeth Hospital in 2001. 2003. 2001, I went to Holland, 2003 in the northeast of England. I joined the CMA in 2008. I did so as a result, some of you might know this already, I did so as a result of an incident in my local area where a young Polish doctor was put under tremendous pressure to participate in abortion. And when she refused to prescribe the medications that were being used to initiate the abortion process, it caused amazement on the ward that somebody actually would stand up for their conscience in that way. She was heavily criticized at the time by the consultant on call, who later apologized to her. But I was so impressed by the courage that she showed, because she knew nobody in the hospital. She was very new to the country, new to that hospital, didn't know if anybody would support her. And when I heard her story, I was determined that there must be some organization out there to help young Catholic doctors, young Catholic healthcare professionals to remain faithful to the teachings of the church, so that their conscience will be respected, but at the same time they'll still be able to carry out excellent work within the National Health Service and in medicine. So I came across the Catholic Medical Association. I think Ian Jessman was who I see his name is here tonight. He was the first person I think that contacted me from the CMA and sent me a registration form. Yes, that's when I joined, and I was elected to council in 2010, having joined in 2008. And then, as Nigel said, I was president of the association for 3 years, from 2018 to 2021, which coincides nicely with most of what we're going to be talking about this evening. So I want to talk in detail, I think, about my experience with the abortion pill reversal service in the UK. Just a little bit of background first. The majority of abortions nowadays are carried out by pharmacological means. So in the United Kingdom, and the figures for 2020, and it's probably even more at this stage, 85% of all abortions were pharmacologically induced rather than surgical. And that means it's a two-stage process where two drugs are given, or two different medications given. On day one, they're given mifepristone, which is a specific progesterone receptor antagonist. So it blocks the action of progesterone, which is essential for maintaining pregnancy. That's why progesterone is called progesterone. It's pro-gestation, pro-pregnancy. So it can't have its effect if something is blocking the receptors to which the progesterone molecules would normally bind. And the second drug, which is taken 1 or 2 days later, 24 to 48 hours later, is misoprostol, which is a prostaglandin analog. So mifepristone, the first drug, it interferes with the process of decidualization or formation of the endometrium. And it causes necrosis of those tissues, resulting in placental or the developing trophoblast, the developing placenta separation from the inner lining of the womb. And the second drug, misoprostol, being a prostaglandin, causes intense uterine contraction and expulsion of the embryo, the fetus, the other products of conception, and thereby with the intention of completing the abortion. Not all abortions are complete, by the way. There's a number of women who undergo and correctly take the two abortion pills will still require surgical evacuation a short time afterwards. So it's overall about a 6 to 7% failure rate in terms of complete evacuation. However, if a mother who's pregnant takes both abortion pills, there's a 98 to 99% guarantee that her child will not survive. So they're lethal in terms of causing death of the developing embryo or fetus, depending on the stage of gestation. If a mother takes the first abortion pill, the mifepristone, but if for some reason she doesn't take the second abortion pill, the misoprostol, there is about a 20 to 25% chance overall that the child might survive, the pregnancy might continue. Again, that depends on a number of factors, particularly the age of gestation. Other factors might be important, such as the health of the woman, her obstetric history in the past, stage of pregnancy, and there might be other. I myself think that socioeconomic factors might be an important aspect, and that was something I noticed in terms of success and failure among the women that I counseled and treated. And there may be other unknown factors that we don't know as yet. If, as we intended to do, a mother has taken the first pill, mifepristone, to start the abortion, but changes her mind, doesn't take the second pill, misoprostol, but if in the meantime she's given progesterone to try to counteract the effect of the first pill, remembering that mifepristone is a specific progesterone receptor antagonist. So if she's given large doses initially of progesterone and continues the course for some time, we can improve the survival rate from 20-25% up to at least 50%. So in the UK, our figures show a survival rate of 50-55%. The United States, where the process is much better known, there's greater awareness of it, and also the timing of when the medications are introduced is much quicker compared to the UK. The success rates are up to 70%. Again, there's room for improvement, and there are ongoing studies looking at other ways in which it might be possible to make the progesterone treatment that we give a little bit more effective. I probably should point out that this is, to avoid any confusion, this is nothing to do with emergency contraception, the morning after pill, very early pregnancy, or abortifacient. This is mifepristone, misoprostol are used in established pregnancies. So we're talking about at least 5, 6, 7 weeks. In the UK, they can be used up to 24 weeks. In the United States, legally, they're only allowed to be used up to 10 weeks in pregnancy, or 9 weeks and 6 days. Pills by post has changed the game somewhat. It has certainly contributed to the increased number of medical abortions being carried out. It's probably led to abortions being carried out slightly sooner than they might otherwise have been. in the UK, in England and Wales, and I presume Northern Ireland, that the timing for the pills by post is meant to be within the first 10 weeks. I think in Scotland allows an extra 2 weeks, up to 12 weeks. But in the United States, they're not supposed to have pills by post, or sorry, medical abortions after 10 weeks. We know from reports that that has been abused, that women have obtained either surreptitiously or in other by legal means pills, and have used the medical self-induced medical abortion even well beyond the legal limit of 24 weeks. It's advised, however, that the Royal College of Obstetricians certainly advises that women who are 14 weeks or more should not have medical abortions at home, that they should be performed in a clinical setting. So our aim is to interfere with the process after the first pill has been taken, mifepristone, because it gives a slight window of opportunity that you don't have, for example, with a surgical abortion. But if a mother does change her mind, and some of them do change their mind, there is a chance that her baby can be saved. So that's where we stepped in. We knew nothing, I knew nothing about this. I don't think anybody in the Catholic Medical Association knew a whole lot about it before 2014. They had already established a program in the United States in 2012. It was up and running. They were collecting data. There was a national helpline that was helping women throughout the United States with doctors registered with the helpline that could provide progesterone treatment quickly to women who requested it. So from 2012, that was already established. There had been a small number of cases of successful treatment with progesterone for women who changed their mind even before that. The first known case, I think, was 2007. A doctor called Matthew Harrison in either, I think it was North Carolina, possibly South, but North Carolina, was just approached on one occasion by someone who knew a girl who had taken mifepristone and desperately wanted to save her baby. And knowing what he did about progesterone and progesterone receptors and antidotes for poisons, he thought, well, maybe if we can give progesterone, it might help to save the baby in this case. And it worked. And about a year later, a very similar occurrence happened in California, where George Delgado, who was working in San Diego at the time, got a call from a colleague in, I think it was New Mexico, Albuquerque, a woman, again, same thing, had taken the first pill and wanted to try to save her pregnancy. And this colleague knew that George Delgado had a good deal of experience with progesterone and natural procreative technology and fertility management. And George Delgado thought exactly the same way as Matthew Harrison had thought, that maybe, just maybe, if we give progesterone, it might flood the receptors, prevent the ongoing effect of mifepristone, and save the baby. And again, that was a successful treatment. I think those first cases were that the mothers received intramuscular progesterone, which is not so widely used nowadays. The other formulations tend to be used. And certainly in this country, it wouldn't be a practical option to give intramuscular injections in an emergency setting. So as I mentioned, in 2014, we became aware of it. By that stage, I was on the CMA Council, Catholic Medical Association Council. And at our November 2014 meeting, Jack Scarisbrick, the founder of Life, was invited to talk about this new wave of treatment that was coming to us, or that we'd heard about from the United States, where women who had taken mifepristone, the first abortion pill, were somehow managing to save their pregnancies in increasing numbers if they were given progesterone treatment. And Jack Scarisbrick, he was informing us about this because none of us had any knowledge of it. We hadn't read any papers on it. We have to say, I think, looking around the room at the time, we were all a little bit skeptical. We certainly sympathized that it would be great if something could be done for these women who obviously had a change of mind and wanted to save their babies. But we were a little bit doubtful if it might be possible. We'd heard that mifepristone avidly binds to progesterone receptors, making it really difficult to displace it if it's already bound to a sufficient number of receptors, that the effect can be devastating very quickly. So we were a little bit skeptical of, would this work? We were also a bit concerned about possible safety aspects. Would it be safe for the mother? We didn't have too much concern about that. There was good evidence that progesterone was used widely in other areas within pregnancy and in obstetrics, IVF, and for helping some women, even at that stage, with recurrent miscarriage. So we knew that it wasn't likely to cause any harm to the mother, but in the event that if the child survived, we were concerned, would it have any long-lasting impact on a surviving child, thinking of thalidomide and affects the structural congenital abnormal effects that some drugs might result in if the fetus is exposed to them in early pregnancy. So we had these concerns, but we decided, we reassured Jack Scarisbrick that we would look into it, and we'd research as much as we could. There wasn't a lot of information around in 2014. There was some small anecdotal cases reported, but not a lot. Although we did notice, I think, quite early on that there was opposition to this abortion pill rescue or abortion pill reversal service. Some of the very vociferous, outspoken abortionists within the United States were very much opposed to this idea. First of all, the initial objection they had was that, well, women don't change their mind. There's going to be such a small number that it's not even worth talking about. So that was the first objection. When it later became pretty clear that women do change their mind, and many of them do, and probably many more would if they could, or if they were given that option. The next argument was, well, yeah, women might change their mind, but this doesn't work anyway, so what's the point? But then when it became clear that it actually was working, and at this stage in the United States, there's been over 3,000 babies, healthy babies born, whose mothers had taken initial mifepristone, but then subsequently managed to receive progesterone treatment in one or other formulation. So the argument that it doesn't work is becoming less and less believable, credible. So the argument that the more recent one that they've been using is, oh, it's dangerous. Yeah, some women change their mind. Yeah, it might work in some cases, but it's dangerous. It's too high a risk. We can't expose women because it'll increase the risk of severe hemorrhage. And they're basing that on a paper which I'll deal with in a little while. It was published in 2020. That argument about danger is again slowly being eroded away. We know that mifepristone is dangerous. We know that misoprostol may be a little bit less dangerous, but mifepristone can kill women and can cause severe complications. But there's no evidence that progesterone, even after mifepristone, causes any problem for the mother or for the child. So the argument that it's dangerous is slowly being chipped away. So there'll be some new argument probably coming in the coming months or years. As I said, we looked into it. Not a lot happened. I saw a few TV programs, interviews with George Delgado on programs like EWTN, channels like EWTN, and we had small anecdotal cases. The turning point for me actually came in 2017. The New York Times, surprisingly, did a very well-balanced article called, I think it was entitled, Abortion Pill Reversal, the New Front in the Abortion Wars. And it gave pretty good accounts from both sides of the divide, from both sides of the argument. George Delgado was interviewed. On the other side, Daniel Grossman, who's probably the most outspoken opponent of APR in the US and in the world, he spoke how this was junk science and there was no evidence base for it. And at that stage, they had about between 500 to 1,000, I think, live births, possibly babies already born, without any increased risk in congenital malformation. Again, I'd reiterate. However, the most convincing statement that I found in the whole article was from a professor from Yale Medical School, a professor of placental research, which is quite a niche area, called Harvey Kleiman, who described himself as being pro-choice. But his statement was, this makes absolute biological sense. And he's someone who knew quite a good bit about placenta, developing placenta, progesterone receptors, and he had looked into it. And he felt this would make absolute biological sense. And he declared that if his daughter was pregnant and accidentally took mifepristone and wanted to save her pregnancy, he would give her high-dose progesterone for at least a few days in the hope that it would prevent or overcome the potentially devastating effect of the mifepristone. And he added, and I bet you that would work. So when I saw that statement from that authoritative figure, I thought this is certainly something that we need to take seriously. 2018, at our annual CMA conference, Claire McCulloch from Good Counsel was one of the guest speakers, and she pleaded with the CMA, because at that stage, her organisation and probably several of the other pro-life organisations in the UK were receiving increasing number of calls from women in desperation who had taken mifepristone but really wanted to save their babies. Some of them had looked up the internet and saw that there was a possibility, but there was no help available for them in the UK, until Claire did approach some private practitioners in Harley Street, apparently, and she has the receipts to prove it, who were prepared to see these women on some occasions if they were living locally, to perform scans, blood tests, and possibly give progesterone if they felt it was still a viable pregnancy. We don't know the outcome we don't know how many women may have been treated or helped in this way. We don't know what the outcome was, but it's likely that at least some of them may have been successful. Claire might know more about that, but there was no established service within the UK. It was very much ad hoc. Find a doctor if you can, who might be willing and able to help. At our 2018 council meeting, or later in the year, we discussed the issue again, and we decided, yes, we definitely had to do something. I was already going to attend the American CMA conference in Dallas that year. And luckily, George Delgado was one of the speakers who gave a very helpful presentation on abortion pill reversal, giving women a second chance. I attended that and I spoke to him afterwards, and I began to realize that this is important. It's something that could work in the UK, and we've got to try and establish it. So when I come back, we discussed it again, and we decided we were going to write to the correct bodies, associations, to see could we help someone to set up an abortion pill reversal service in this country, preferably through the mainstream medical services. So we wrote maybe naively to the presidents of the Royal College of Obstetricians Gynecologists. I think at the time was Leslie Regan, although she handed over to somebody else afterwards. We wrote to the president of the College of GPs. We wrote to NHS England, explaining the background to APR, explaining how enthusiastic we were about it, given the evidence from the George Delgado paper and other anecdotal cases, the numbers that were coming through from the United States, the safety record, the efficacy record. And we thought that that people would be jumping with enthusiasm for this. We were a little bit disappointed, although we probably shouldn't have been too surprised, that there wasn't any support coming from the three bodies I mentioned. All of them had some excuse. We got a joint letter eventually after several months from the RCOG and RCGP saying that they could not support a treatment with a medicine that was unlicensed for this use. Now, we wrote back to them because they neglected to add misoprostol, the second abortion drug, is not licensed for medical abortion. It's licensed for management of peptic ulcer disease, but it's not licensed for medical abortion. And yet they were very happy to advocate it and use it widely in that context. We also added in a respond letter that methotrexate, quite a dangerous drug in the wrong hands, is highly recommended by the RCOG for the medical management of ectopic pregnancy. And that is not licensed for that indication. It's licensed for other indications, particularly chronic inflammatory conditions like rheumatoid arthritis, but not for the medical management of ectopic pregnancy. So we wrote back to them, pointing these diplomatically and respectfully pointing out these inconsistencies in their argument, but we got no further response. NHS England didn't say a whole lot except that they couldn't support an APR service because there wasn't sufficient evidence there wasn't a sufficient evidence base to support it. We pointed out to them that the evidence base, but they just ignored what we said. Interestingly, nobody raised any mention of danger at that stage. That was a much later development when they realized that everything else was failing. Nevertheless, we wrote back to these august bodies and got no response. So we decided then we would write to the GMC. Philip, I'm not sure Philip is here tonight. Philip was very keen that we should pose a very direct question to the GMC, asking them a very simple question. If a woman changes her mind, so in effect she's withdrawn her consent from medical abortion, changes her mind after taking mifepristone, and she approaches a doctor for help, what is a doctor supposed to do? That sounded like a very reasonable question. We got a reasonable response from the GMC, and this turned out to be, again, quite important in the longer the bigger scheme of things. They said that they couldn't comment on specific clinical matters, which is fine. That would be beyond their remit, although they did it in my case. But they pointed us to their own literature, to their good medical practice guidelines, that every patient has a right to know all treatment options available to them at any time. They have a right to know of any alternative treatment options rather than the one that they may have been proceeding along. They're entitled to withdraw the consent at any stage and to be considered for alternative approaches to management. And while it wasn't definitely saying this is a great thing that the country needs, it certainly wasn't thrown up any warning or any objection that we mustn't go down this route with abortion rescue treatment. We then wrote back a third time to the two colleges and the NHS England, just describing our response from the GMC, quoting word for word exactly what the GM said in response to our question, hoping that they would respond to us, but we got no response. At the end of those letters, however, we did say, we presume at this stage, unless you have some major objection, that you will not object to us going public on this issue. So at that time, we were determined we were going to have to find some way to set up a service here for women who are calling out for it and who need it. But the next problem was, how do we get progesterone to these women? How do women know about this service? We thought initially we were going to have to try and inform every GP in the country, every accident and emergency department in the country. We even we had negotiations with SPUC, who were actually very helpful, and they devised a very nice leaflet with all of the information that a GP would need to know, and that the general public would need to know about the indications for this, the treatment regimens, possible side effects to watch for, success rates, failure rates, and references to all of the points we had made. So these leaflets were made by SPUC. I don't know, I've never actually seen them. I don't know if they've ever been distributed. We did anticipate that the majority of doctors would probably look at them and throw them in the waste paper bin. But even if 3%, 5%, 7% took them seriously, it could be a good start. But still not a lot was happening until April 2020. At that point, a wonderful man in Ireland called Phil Boyle, Dr. Phil Boyle, who was already carrying out some abortion pill reversal treatment for women in the Republic of Ireland. Remember, abortion had only been legalized there, and well, after the referendum in 2018, it became legal in 1st of January 2019. So it was a new sphere for them to have to deal with. But Phil was already engaged in helping some women in that situation. And he got a call one day from a US-based helpline called Heartbeat International, who are based in Ohio, and they run the abortion pill reversal or abortion pill rescue network in the United States and now internationally as well. Phil was registered with them, and they got a call from a woman in England. Now, being American, they probably thought Republic of Ireland, England, well, there's not much difference. So they rang Phil and asked, could he help this woman looking for support? Phil apologized, said that he wasn't licensed or he wasn't registered to provide prescriptions for women in the United Kingdom, but he knew someone who might. So he called Eileen Riley, the obstetrician gynecologist in Glasgow. I'm not sure if she was able to help on that specific occasion, but Eileen then realized this was a way that we could try to at least be available for women who came looking for help. Eileen then informed me, and we both registered, she a little bit before me, we both registered with the Heartbeat International website, saying that we were very interested in providing this service for women in the UK. We gave our contact details that if women did approach their website, that we would be very willing to speak to them, and if possible, try to get them progesterone therapy to save their babies if we felt that was likely to be helpful in individual cases. So Eileen started April 2020. I had my first case in June 2020, the end of June 2020. Initially, though, it was slow. There weren't, possibly because the helpline didn't really know who we were. So we didn't get many calls, but by September, the calls were coming through pretty regularly. So certainly by the autumn time, we were getting at least 6 or 7. I personally was getting at least 6 or 7 calls a week. Eileen was probably getting maybe not quite as many because I was slightly more available during the daytime hours, and Eileen's in theatre quite a lot. But we were getting between 5 and 10 calls a week. On some days, we would get three in one day, particularly at weekends. Well, Eileen says she did help that lady and it was successful. Great. Thank you, Eileen. So we were getting, so weekends especially, we tended to get sometimes 3 calls in a 24-hour period. The problem was trying to get the treatment for them. But again, Eileen had shown me that how this was possible through using, to some extent, what the abortion people have been doing, using telemedicine. That once we spoke to the mother and gave her all of the details and were certain that this is what she wanted, that she gave her full consent to go through with the treatment. We then, because we knew what area of the country she was living in fact, I used to do it even before I spoke to the mother. I'd look up to see what pharmacies were available in the area, particularly in the evening time, what pharmacies might still be open, because a lot of them close at 5 o'clock or 6 o'clock. So we tried to find pharmacies local to the mother. I'd always ask them, is there any pharmacy you don't want me to contact? Because keeping in mind that this could be a very sensitive issue. Some women may not want their next door neighbor or someone they know very well finding out what the treatment that they're receiving and putting 2 to 2 together, why are they getting this high dose progesterone treatment. So we would try, with the mother's permission, we would contact a local pharmacy, asking them, first of all, did they have progesterone in stock? There were 2 formulations that we were using. I was using almost exclusively oral progesterone. Being a non-gynecologist, I felt more comfortable doing that. But also the evidence from the United States suggested that there was a better success rate with oral compared to vaginal pessary progesterone. And also, it was much more available. Pharmacies, I found out pretty quickly, were more likely to have the oral formulation in stock, whereas they might have to order in the pessary treatment. And it was cheaper because this wasn't normal NHS treatment, so it had to be paid for by somebody. So it was more available, better evidence base, possibly. The only exception would be if a woman was vomiting very profusely, then I would have had to look for alternative method of administration. Eileen, on the other hand, being very comfortable and used to using progesterone pessaries, that was her go-to formulation, was to get pessaries for the women. And interesting, we had very similar success rates, which I'll come to in a moment as well. While the American papers suggested that the oral progesterone treatment had up to 68% success rate and intramuscular 64%. The vaginal pessary was only around 50%, maybe even slightly less than 50%. But the numbers were different in each group and they weren't randomized in a proper way to each group either. There may have been other factors to account for those differences. Similarly, in ours, we got a variety of women of all age groups, different stages of gestation, different time delays from taking mifepristone to starting progesterone treatment. But overall, we had very similar success rates of 50 to 55%. To give the actual figures, when I started the end of June and up until we were eventually stopped on the 28th of April, 2021. Between the 2 of us, we took 144 calls. Now, not all of them were genuine. We know there were at least 3 or 4 that were fake calls, hoax calls. Eileen and Heartbeat International were the victim of a hoax sting operation by a person who called herself an investigative journalist, or calls herself an investigative journalist, who pretended to be a woman in distress looking for help, and then wrote a scathing attack on APR and on the doctors providing it. But having said that, the consultation with her was actually held in a very professional and very sympathetic and caring manner. So she didn't have a lot really to go on. So 144, I counted 92, and I think probably about 88 to 89 of those were probably genuine. And of those, working backwards, 32 babies have been born, and that was, of the women I counseled, 20 live babies, or live, healthy, happy babies have been born. Out of probably about, so 32 out of 67, which is slightly less than the 50%. It's actually 48%. However, we both for Eileen and myself, a number of the women were still pregnant, and the treatment seemed to be working for well over 4 weeks, so more than 28 days after they had taken the mifepristone and after they had commenced the rescue treatment. So initial scans were fine. In some cases, follow-up scans were fine. And then subsequently, the baby was found to have died. they may have been miscarriages or deaths that would have happened anyway. We know that 10 to 15% of early pregnancies will end in miscarriages, with or without, even without mifepristone or progesterone or any other interference. So it's possible that some of these, what we would consider unsuccessful or failed treatments, may have been doomed to fail anyway. So if we wanted to be very blunt and very harsh about it, our success rate was 48%, 32 live babies. If you took away the women where, or the cases where there was a late miscarriage or a late death, the success rate actually goes up to 54%. If you included those as being, actually they were successful in that the progesterone successfully overcame the effect of mifepristone, but wasn't, the baby died for some other reason, that would bring the success rate up to 58%. So I think a fair estimation of how successful the treatment is 50 to 55%. Mentioned 144 sort of contacted us. Not all of them, and not all of them were genuine, but the majority were. Of those 144, however, only 91 actually commenced treatment. Now, a number of women, and we have this from so many sources, a number of women told us, yes, they would really like to, having heard the explanation, they would really like to save their babies, but they couldn't because they were under so much pressure from other sources, usually partners or boyfriends, or in some cases other family members. In some cases, and at least two that I'm aware of, social workers or social services were putting women under tremendous pressure to not continue with their pregnancies. And in one case, a GP had persuaded a woman that seemed to be doing okay with treatment to stop it after a few days, and she subsequently miscarried. And we know that the abortion providers, Mary Stopes, certainly on two of the women that I helped, had gone back to Mary Stopes to tell them that they changed their mind, and then Mary Stopes persuaded them that this progesterone treatment was nonsense and they should go ahead with the abortion, which they did. So there were a number of reasons why some people didn't start treatment. In other cases, it was because it was too late. That by the time they rang us, they already were passing very large amounts of blood, clots, severe cramping, and it probably wasn't worthwhile in those cases. If it was light bleeding, however, and many of the women that we helped did have spotting or very light bleeding early on, even after they commenced the progesterone. But it was always worthwhile in those cases to encourage them to continue with the treatment, because even with some bleeding, and I can only put this down to that the womb is a big place for a small developing embryo or a small early developing fetus, and bleeding can come in a patchy pattern. So it might come from one part of the endometrium that is well away from where the baby's developing. Because we had, in fact, I would say in almost, if not all of the women that I treated who were in the first trimester, certainly under 10 weeks, if they'd taken mifepristone, they all had some bleeding, even those who subsequently had successful outcomes. Whereas the only ones who didn't bleed were those who were already well into the second trimester. And you could argue they may well be the 20-25% that were probably going to survive anyway, although you don't know that for certain. So we treated those women as well, in the hope that we were at least increasing the likelihood that their babies would survive. A number of the women that we dealt with were lost to follow-up. So some women seemed to be doing fine, and then they stopped answering our text messages or calls. And well, we had to respect that. We couldn't keep chasing them. So it's likely that at least some of those cases that the women, either by coercion or by free will, had changed their mind and decided they weren't going to continue with the pregnancy, they were going to go back to the original plan and then proceed with abortion. So overall, so 32 babies eventually born, giving an overall success rate of 50 to 55%, depending on what way you want to consider those that had late miscarriages, which isn't as much as we'd like. However, keeping in mind that the success rate in the United States up to 68%, possibly up to 70% in some places. But there's much greater awareness. In fact, in some states, it's mandatory that women must be informed about this option available to them if they change their mind. So even the abortionists who are providing the abortion pills must, in some states, inform the woman, if you change your mind, I'm obliged to tell you that you can apply for progesterone treatment. And some people say this might help you to save your pregnancy. So they don't like doing it, but they have to do it in some places. So the delay in terms of getting rescue treatment in the US is generally less than 6 hours. In the UK, the average time is 24 to 25 hours. Some of the girls we helped were much quicker than that. Some were 72 hours. They say that it can be successful up to 72 hours. So even if it's 2 days, 2.5 days, coming up to 72 hours, and if there hasn't been major bleeding, major cramps, it's still worthwhile considering progesterone treatment for those ladies. The treatment we actually gave, as I said, I gave oral treatment, which was utrogestin, which is oral micronized progesterone. The dose is 400 milligrams, for those who maybe doctors might be interested. 400 milligrams twice, so 400 milligrams immediately, and then another 400 milligrams that same day. So even if it's late in the evening, give another one at night. So 400 milligrams twice a day on the first day, taken as quickly as possible. And then 400 milligrams twice a day for 3 days. So day 1, day 2, day 3. After 3 days, if everything is still okay, reduce it down to 400 milligrams once a day or 200 milligrams twice a day. Progesterone can be quite nauseating, and some of the ladies that I had helped preferred, and I encouraged them to split the doses in that it was better tolerated in some cases. And also if they took it with water or with food, it was also better tolerated. Because it can be quite nauseating, it can make you very tired, can cause headache for some women, can make you dizzy. Eileen used cyclogest, which is vaginal pessaries, and slightly different dose. I think she was given 400 milligrams 3 times a day for first few days, then twice a day for a few days, and then once a day. We continued the treatment well into the second trimester. By the second trimester, by week 12, 13, 14, the placenta should be starting to produce, it should be producing good amounts of progesterone, that it shouldn't be necessary to continue with high dose treatment indefinitely. So if we can get them to week 14, week 15, so I usually encourage the women and gave prescriptions for them to continue treatment till the end of week 14. If they were already in the second trimester, which 4 or 5 of them were, I just gave them 2 weeks of treatment. So again, twice a day for the first 3 days, then once a day for a total of 14 days. And I think all of those, in all those cases, the baby survived, unless they had changed their mind in the meantime. So we were happily doing this. We were looking forward to getting up to 150 and going beyond that, thinking that this was much more than we expected. Initially, when we started, we thought we might get maybe 1 or 2 a week, but this was much more than we had anticipated, and it was likely to increase as word got around that this treatment was available to them. Word did get around to people who didn't like what we were doing, and actually from January, one of the girls that I had treated in January, who had went back to Mary Stokes to say that she had changed her mind, that I think that brought this process to their attention, because I'm pretty certain it was on the basis of that one case that they then launched their attack in orchestration with the Royal College of Obstetricians and Open Democracy, that group that did the scathing attack on APR, and possibly others that might have been in the background as well. But we were totally unaware of this, apart from the telephone call that Eileen had, and then the subsequent report in the Guardian and on the Open Democracy website. We were happily continuing the treatment, not knowing that there was any major problem with it. It's interesting that the CMA is one of many groups that was invited to take part in the GMC's Equality, Diversity and Inclusion Forum, Strategic Forum. This was set up in the wake of the Bawa Garba case a few years ago, where the GMC was correctly found guilty of racism within the organization. So to try and show that the GMC wasn't a racist organization, they set up this Equality, Diversity, Inclusion Forum to give minority groups, faith groups, an opportunity to come together and express their concerns and workings within the GMC. So the Catholic Medical Association, along with the Jewish Doctors Association, the CMF, Muslim doctors groups, Sikh doctors, LGBT doctors, disabled doctors, African doctors, Pakistani doctors, Indian doctors, Cameroonian doctors, we're all invited to take part in this forum. And we had to give a little report at each meeting. It had been going for 2 or 3 years by the time COVID came along. So we're having Zoom meetings by COVID era. And in early April 2021, last year, I was asked to just give a brief account to what the CMA had been doing, and I innocently gave a full report on some of our members. I didn't mention who or how many. Some of our members had been helping women who regretted taking the first abortion pill and who wanted to save their babies, and we were providing them with this progesterone treatment because the evidence was that this could be effective and was very safe. And I even gave the numbers that we had treated to that point, the numbers of babies that had already been born, and that everything was going according to plan. And at the end of it, the chairperson said, "Thank you very much, Dr. Kearney, that's very good." And then he moved on to the next group for their report. I'd also, in early March of that year, I had spoken at a parliamentary committee meeting. This was organised by a coalition called Care for Women, of which the CMA is also a member, concerned about the pills by post situation. So we were trying to raise awareness of our concerns. And I was asked to speak from the medical point of view of risks of coercion and surreptitious use and so on, and trafficking, and how easy it is for traffickers if you can obtain pills by post without any face-to-face consultation. So I gave the medical concerns that we had. I was asked to speak for 15 minutes, so 7 minutes on pills by post. I was asked to speak for 8 minutes on abortion pill rescue because word was getting around that this was an exciting new form of treatment for women seeking help. And it was chaired by Lord Mackay and attended by a number of other parliamentarians, and was general excitement, and people asked lots of very good questions, and we created an awareness. We certainly weren't trying to keep this hidden. The report from Open Democracy, I think one of the MPs from either Liberal or Greens parties had said that this under the radar treatment was using women as guinea pigs or something. But we certainly weren't trying to keep it under the radar. We're trying to publicize it and create as much awareness as we could about it. And certainly the GMC were aware about it. So we told them in advance that we were thinking of doing it, and we told them when we were doing it and the results we were getting. So on the 28th of April, 2021, around lunchtime, both Eileen and myself, within a minute of each other, received an email from the GMC stating that complaints had been received from several sources about our activity in providing abortion pill reversal treatment, and that we were summoned to attend an interim orders tribunal hearing to face disciplinary measures because we were possibly guilty of serious professional misconduct by what we were doing. And then we received, the next day, we received the formal allegations that were against me. There were 10 in total. Some of them were just so ridiculous, but one of them was that we were using an unlicensed medication, which I've already dealt with. We were using it in a remote fashion, which was exactly what the abortion pill providers were doing. Without an evidence base. We'd already provided the evidence base for anyone who cared to listen. Probably the most ridiculous one against me is that I wasn't following the NICE guidelines relating to abortion care. I don't provide abortion. I wasn't no intention of providing abortion. I might as well have said I wasn't providing the NICE guidelines relating to management of atrial fibrillation or rheumatoid arthritis or inflammatory bowel disease. I wasn't dealing with women in any of those situations. I was dealing with women who wanted to save their babies, preserve their pregnancies. Another allegation was that I'd offered, and it was true. I think most Catholics and Christians would look on it as an act of charity, but I'd offered in some cases where of financial hardship, that if the mother couldn't afford to pay for the treatment, because I did at the end of each consultation, I had to tell them that this was not a normal NHS treatment, and unfortunately it had to be paid for. And the inevitable question that everybody asks is, how much will it be? And I would tell them it'll be, depending on what part of the country you're in, it'll be about £10 per week. So if I give you 2 weeks treatment, it'll be about £20. 3 weeks treatment will be £30. Most of the women said, that's fine, that's no problem. Some of them said, I just can't afford that. So I said, if this is really what you want to do, if you really want to save your baby, and this is the only thing preventing you, I am very happy to provide you with some financial assistance. But what I did is I would just transfer into their account the exact amount. So I wasn't paying the mother as such, I was paying the pharmacist, but through the mother. And that's eventually how we answered that question. And our expert witness was very supportive in that. Anyway, these allegations came and we had to prepare. We had less than 2 weeks to prepare for our IoT. Christian Concern were very good. When word got around that Eileen and myself were in trouble, Christian Concern were first off the mark actually in offering to help. They've been down this road before in other areas, but not in dealing with the General Medical Council. I found that they were bemused. The Christian Legal Centre at the legal wing of the Christian Concern were very bemused or amused by the goings on in the GMC and the IoT when we met face to face, described as a kangaroo court with good reason. We had to inform a number of the pro-life organisations what had happened, because some of the referrals, the majority were coming to us through Heartbeat International. We were getting some direct referrals from SPUC and Good Counsel and some other crisis pregnancy centres. So we had to inform these groups that we now had to stop this, and we had to explain why. So Christian Concern heard about this through this network, and within 2 days we had a meeting. So we heard on the Wednesday. Friday morning, Eileen and myself were invited to a Zoom meeting with Andrea Williams, Mike Phillips, and a couple of others from Christian Concern who really wanted to help us. ADF also, to be fair, also wanted to help too. They were a little bit slower, and they said, "Oh, we'll have to talk with our bosses about this," but they offered to be there for us if we needed. I was particularly impressed with Christian Concern because straight away they identified what the problems were. They identified what we needed to do, and they said the first thing we need to do is get an expert witness on our side to give an expert to look at the allegations and give his independent expert witness report. Mike Phillips knew somebody who was a gynecologist obstetrician in the Southwest who was recognized by the courts as an expert witness in this area. And he's not pro-life, he's not a Christian, he performs abortions. He certainly has no problems with people performing abortions, but he was very happy to look at the allegations and to give his honest opinion. And within a matter of days, we had an excellent expert opinion report answering the questions that he could answer. There were some of them that he didn't know. He wasn't privy to all of the information. He was very happy to give the report, and we submitted that to the court in time for the IoT. When the IoT came around, we were a little bit dismayed. Eileen, by the way, Eileen decided to go with on the advice of one of her mentors. She decided to go with one of the secular medical defence unions in Scotland, the Scottish Medical Doctors Defence Union. So myself, which in a way maybe turned out to be a good thing that we had two different approaches to the questions. So we were both ordered to attend the IoT on the 12th of May. Two separate hearings. I was in the morning, Eileen was in the afternoon. And my solicitors, my barrister was a little bit taken aback because we had prepared a very good defence. I'd answered all of the allegations point by point. Which I thought were reasonable answers that any reasonable person would accept as being trustworthy. But we were dismayed at the very beginning, the IoT, the chairperson made it clear that this was not a fact-finding procedure, that it was purely to look at the allegations and the seriousness of the allegations, which I suppose you could look on it like a pre-trial hearing to see, does this need to go to trial, which you'd understand that. Anyway, we went through the motions of sitting through, given Mike Phillips gave a very good account of himself on my behalf, but at the end of it, but the GMC, there's 2 points I'd like to make. The GMC, first of all, they called for in both cases, for complete suspension. So they wanted the two of us, because we were such a danger to the public, they wanted us suspended for 18 months to allow an investigation to take place, but not allow us to have any medical practice in that time. They felt that this was in the public interest. The IoT, luckily, unfortunately, decided that was a bit disproportionate. Maybe it was they were haggling, and maybe they thought if they asked for the most extreme, that they would at least get something less extreme. But the IoT said that would be disproportionate. That in both our cases, we had very good reports from our own hospitals, from our own medical directors, our own line managers, that there was no problem with our normal everyday practice. So they felt that, particularly in a year of COVID, when they were trying to persuade dead doctors to come out of the grave and retired doctors to come back to work, that there was such a shortage of doctors, it would have been probably a little bit silly to suspend completely two relatively experienced, honest, hardworking medical and obstetric consultants from their normal NHS work. Anyway, so we both had conditions applied to us rather than complete suspension. To the point I want to make, I thought I was quite offended by the legal representative of the GMC, and he called me disingenuous. I smiled initially, but then when He called me disingenuous because I had dared to suggest that the GMC approved of what we were doing from the correspondence we had with them in 2019, and also that I had the audacity to bring up the report from the Equality, Diversity and Inclusion Forum, which I'd given just 3 weeks earlier. He felt that, how dare I mention these, that I was trying to suggest that the GMC was fully supportive, which I did nothing of the sort. I just included word for word the exact quotations from the GMC on both of those issues. So I was a little bit offended that he was so vindictive, I'm thinking, or vicious in that regard. Anyway, in my case, the conditions were applied that I was allowed to continue practice medicine on the conditions that 1, 2, 3, 4, 5. The main condition was that I must not administer, prescribe, or recommend progesterone for abortion reversal treatments. Word for word, must not. I must not carry out any private work or any, which I don't do anyway apart from this, or any voluntary work without express permission from the GMC to do so. So they were really making sure that I didn't do anything that would allow me to help women looking for this supportive treatment. And this was to be reviewed, that these conditions were to be imposed for up to 18 months, but were to be reviewed with routine hearings every 6 months in the meantime. Eileen had similar conditions imposed, except as a gynecologist, I think they must have realized they can't stop her from prescribing progesterone. So they found a different way to make sure that she didn't participate in this treatment. So they regulated that she must act under clinical supervision. She must not perform any voluntary work or any private work outside of her normal NHS capacity without express permission of the GMC. So in both cases, they ensured that we couldn't carry out abortion pill reversal treatment without breaching the conditions. My legal team decided to appeal it because we felt the strongest evidence is this. Okay, we've got a very good expert witness report, which was totally ignored. They wouldn't even look at it at the hearing, but we thought at least subsequent hearings, surely it'll be taken into account. We also thought that the best defense we might have would come from the women themselves, those who were directly involved in the treatment, in the service. And we knew that none of them would give any bad reports. We knew that they were all very, very grateful, even those where the treatment didn't work, and even some of them where they decided not to go ahead with the treatment. A number of the women who decided not to receive progesterone, but to carry on with abortion by taking the second pills, actually phoned me several days later to thank me and to apologize and to say that they regretted that they hadn't done what I had offered to them. So we knew that we would all round that we would get support from whatever number of women we wanted. Not a single woman complained. So even those who, even quite quickly made up their mind that they didn't want. One girl in particular, I remember, she said, once she heard it wasn't NHS, sorry, I don't want anything to do with it, thank you very much. But then nobody complained. None of the women who received treatment or none of their families complained. So we got through my legal team. I wasn't allowed to influence any witnesses. I just asked the girls, did they give the permission for my legal team to contact them? Then it was out of my hands. So they contacted 10 of the girls, 10 of the mothers, and got very strong witness statements from them. I have to say I was in tears because I wasn't allowed to see them until much later, and I was very emotionally moved by some of the things that they said, which I knew that they were grateful, but I didn't understand or appreciate fully the depth of gratitude until I read some of the statements. And they came from a variety. We got some where the babies had already been born. We got some from the mothers who were still pregnant and awaiting delivery. We got some from women who had tried the treatment and it didn't work and they lost their babies. And we got 2 from women who didn't take the treatment. And we presented these and we appealed, and we were granted an early review in early August, the 3rd of August, thinking early review on the basis of the witness statements that the GMC had provided, apart from the initial allegations, no other incriminating evidence had been brought forward. by any of the abortion groups or by the GMC. So we knew there was no other evidence apart from what we had produced. So we thought, and we were informed that the reason for that the case examiners felt that there was a need for an early review was on the basis of the new evidence that had come to light. And we thought this is looking good. We're going to get it overturned. We vote. We were dismayed, however, at the very start of the early review. So the second tribunal hearing, a different chairperson said, "Well, of course, this is not a fact-finding mission. We're not here to look at the facts. We're here purely to look at the allegations. We won't be determining the veracity of the allegations. It's just to see, do we need to maintain the conditions or not?" That's when my legal team turned their hair out, saying this is just a kangaroo court. Decisions were decided in advance, and there was we'd play along with it because we had to, but we felt we got to get this out of this system. We got to get into a proper judicial system. So they decided at that point that we had to apply to the High Court for hearing on the basis that the interim order was disproportionate, that there was no threat, there was no evidence of any threat to the general public, which is or of professional misconduct. So, and we felt that all of the evidence was on our side. So we appealed to the High Court. Initially, we wanted an expedited hearing, but that was turned down. The GMC appealed against that, and they won that appeal. But their appeal that to the High Court that there shouldn't be a hearing it must have been rejected, because we were granted a hearing much quicker than I expected, because we didn't put the application in until I think either the end of September or early October, and I thought we'd be waiting about 12 months before anything comes up. But we were told quite quickly around Christmas time that our hearing would take place on the 24th of February, and the GMC were informed that at the same time. The GMC had been struggling to find their own expert witness to comment on the allegations and on anything else to do with the case. In fact, in a number of emails to both Eileen and myself, they had admitted that they had difficulty in finding an expert witness to assess the cases. Eventually, they said they had one in December, but then he got struck down with COVID and he couldn't give his report. And then all through January, nothing. Still, we heard nothing. Then, when news came that the High Court was going to have a hearing, myself against, because I was taken to the GMC to court. So Dermot Kearney versus the GMC. This to take place on the 24th of February. Suddenly, the GMC got an expert witness report. And surprisingly, it was actually at least as supportive of APR as our own expert witness, if not even more so. He was particularly strong by pointing out that there was no evidence of any danger associated with APR, that there was an evidence base to suggest that it could be effective. He did recognize there were no randomized controlled trials to support its use, but he felt that the evidence that was there was strong enough that it was there. It was an evidence base that could support its use. He criticized MSI and the British Association of Abortion Care Providers. They had very hurriedly in April 2021 written a quick document saying how against APR, that there was no need for APR, that it was dangerous, that it was ineffective, but it's only distributed among their own members. So he was highly critical of these abortion providers. You know, he himself may well provide abortions, I'm not sure, but he was highly critical of them, claiming that we had no evidence base, when he said at least the evidence that we had quoted is on PubMed. It's widely available, it's on internet searches, anybody can get it. It's in reputable, maybe not the most, the strongest ranking, the highest ranking medical journals, but it's in reputable medical journals. Whereas what they were producing was only for its own members, not available to the general public, not available on the internet for anyone to see. So he was highly critical of the abortion providers in that sense, and much more supportive towards us. He did have some concern about the money aspect and me providing money. He thought that could be construed as possible, me trying to enforce some pressure on the women. But we pointed out in our response, and backed by our own expert witness, that the money was not to the women. It was for specifically and only for the treatment. And as I said, if we could, we would have given it to the pharmacist rather than to the mother, but it wasn't possible to do that. And that was generally accepted. I just want to highlight about danger, because I mentioned that Initially, the opponents of APR said that first of all, there's no need, and that was unproven or proven to be not the case. Then it doesn't work, and then good evidence that actually it does work in very much more than expectant management in own words. And then danger. The reason that they come up with this danger, there was a paper published by another opponent of APR in California called Mitchell Kearney. And now he's on record many times criticizing APR and saying that, well, we must demonstrate that this doesn't work. And I'm going to devise a study to prove once and for all that this is nonsense, that it doesn't work. And most scientists, most medical people with a scientific head will appreciate that you don't go into studies or academic research with that attitude. You go in with an open question, say, I wonder, does this work? Let's set up a valid study to find out. But he was determined to set up a study. So he figured he could do it with just 40 subjects, a cohort of 40 subjects. There's very few areas of medicine where you'll be able to show a statistically significant difference between one form of treatment and another, or a lack of treatment and a treatment with just 40 subjects. That's 20 in each group. Keep in mind that there's always going to be at least a 10% dropout rate in any study. And in something as controversial as abortion, it's going to be probably 20%, if not more. But he got permission, ethical permission. He got a statistical analyst to back him on this, that he could devise this study with 40 people, 40 women. Women who were due to have a surgical abortion anyway, and they were between, I think, 6 and 9 weeks pregnant, but not randomized any other way, were persuaded to delay their surgical abortion for 15 days to allow them to do this academic study. And on day 1, they would be given mifepristone, and on day 2, they would be given either placebo or progesterone in exactly the same doses as George Delgado had recommended, and the same dose that I was given, 400 milligrams oral progesterone, twice a day for 3 days and once a day. And then they were going to have follow-up scans and blood tests to assess the efficacy of the treatment. The trial was stopped early after just 12 subjects had been recruited, allegedly on the because the authors claimed that it was too risky. There was too high a risk of serious hemorrhage. 3 women out of the 12 had to attend the local ER services with bleeding. Didn't say how much bleeding. We know one of them did require a blood transfusion. She was in the placebo group. One of them also required a surgical evacuation, probably due to the hemorrhage. She was in the placebo group. One woman in the progesterone group attended her ER. She was assessed. She didn't require any resuscitation. She didn't require blood transfusion or fluids. Her hemoglobin was 130 or 13, kind of units you want to use, which was normal. So she was allowed to go home. But they felt 3 women out of 12, serious bleeding. We can't continue with the study, it's not safe. It's more likely, and what they don't emphasize, although they mention, but in passing, but don't emphasize, it's more likely that the trial was stopped prematurely because they didn't like, the authors didn't like what they were seeing. So after 15 days, which is still it's too early to say this treatment is effective. We would say you have to go at least 28 days and ideally to full term. But at the 15-day mark, by the way, two women had pulled out of the trial voluntarily within a few days for other reasons, not because of safety concerns. So 1 in each group. So that left 5 in each group. So there was 12 were recruited, 6 in each group, 2 pulled out. So that left 5 in each group. So 5 women had taken mifepristone, were given progesterone. 5 women taken mifepristone, were given placebo. And at 15 days, 4 of the women in the progesterone group were still pregnant with viable pregnancies. 2 women in the placebo group were still pregnant with viable pregnancies. So that was the 80% versus 40% success rate by that stage, which is double the success rate, which is exactly what George Delgado had been saying, exactly what we're saying, that we can improve survival from 20-25% up to 50-55%. So it was reciprocating or reiterating what the people in favor, the proponents of APR, had been saying all along. They also didn't emphasize or just mentioned that the risk of hemorrhage was double that in the twice as much in the placebo group as in the progesterone group. So it may well be that progesterone might reduce that likelihood of severe hemorrhage. Well, we know that women bleed after mifepristone. I mentioned that almost all of the women who took mifepristone in the first trimester that I encountered had at least some bleeding, some very heavy. I'm aware of 2 of the women that I counseled that required blood transfusion. And we know from Kevin Duffy's Percuity Freedom of Information study in this country, published last year, that almost 500, 495 women per month on average, per month, every month, require emergency attendance at local casualty services or local emergency services because of some complication related to abortion pills. The majority are because of incomplete abortion obtained products that in some cases require surgical evacuation, in some cases require antibiotics and surgery. But some are due to severe hemorrhage. And we know that women do bleed. So to say that they stopped the study because women were bleeding after they'd taken mifepristone is maybe stretching it a little bit too far if that was your main safety concern about progesterone. Anyway, we were set to attend court on the 24th of February, and suddenly the expert witness report came through in, I think around the 11th of February. That was passed on then with our answer to his report, passed on to the case examiners for the GMC. And at that stage, at least as far as we're aware, for the very first time, all of the witness statements from the women that we had helped, who had given us witness statements, and all of the evidence that myself and my own expert witness had put forward, that was now in the hands of someone who was actually going to look at it for the first time. So I got a phone call on the 15th of February from my barrister, Mike Phillips, congratulate me on the good news that the GMC had looked at the evidence and had decided that the case should be closed without any further action. So they dropped the case. A few moments later, I got an email from the GMC confirming that was the case. And then 3 days later, on the 18th of February, we had the formal review of the IOT, because the GMC dropped the case, but the conditions were still in place. So the conditions were imposed by the IOT. They had to be revoked by the IOT. So the IOT had a meeting or a get together, a hearing without us being present on the 18th of February, and formally dropped or revoked the conditions at that stage. I'm not going to say anything about Eileen at this stage. Eileen might want to say something herself, but her conditions remain in place. And that was, I think, a pretty telling fact that they only acted in my case because of the threat, I suspect, of the High Court appearance. The GMC did not want to go to the High Court because they had no evidence. You can't go to court with a case and not have any evidence on your side. All they had was allegations, hearsay, complaints from abortion providers, disgruntled abortion providers, but no complaints from, and certainly no evidence to back those allegations from any of the women or any of those directly involved in the service. So Eileen's conditions remained in place even after mine were revoked, and that was several weeks ago. Eileen may want to say something, but I'm happy to answer any questions. I don't know, Nigel, if I may have gone a little bit beyond time there, but
not at all. Thank you so much, Dermot. That was a very compelling and very full account of the whole story of APR. So thank you very much for putting it so well. And we have had some questions on the Q&A. If people want to add questions to the Q&A, please do. Eileen, if you're still there, I think you are, and you would like to speak, please just let me know by putting something in chat. But I'll just start with the questions, Dermot.
Sure.
Well, one question is, you referred to getting several complaints being made to the GMC. As far as you are aware, were these complaints made independently or in concert?
It's difficult to know. They all came around the same time. So I suspect that the negotiations did take place between various abortion providers, because they all took a different angle. Now, the Catholic Union, I think, are aware. I brought to the attention of the Catholic Union the one that I didn't mention specifically, but the complaint from the RCOG was particularly I'm not sure what the right word is used, but particularly concerning, in that they said they weren't so much concerned about the treatment, but they were concerned with the people involved. That's the people involved in providing this service. to quote them from their letter. And then they actually specifically stated that one of them is the president of the Catholic Medical Association. And they implied that as Catholic, they identified Eileen as an obstetrician in Glasgow. But they were implying that Catholics could not be trusted to provide an impartial, appropriate service or care to these vulnerable women. I felt that was a blatant anti-Catholic statement that was endorsed, and that was probably the most disappointing thing of all. And it was disappointing that the GMC allowed themselves to be manipulated on purely political and ideological grounds, but to actually endorse, an anti-Catholic. I took that complaint actually to the Equality, Diversity, Inclusion Forum, and I reported on behalf of on behalf of the CMA, and it was met with stony silence. And they eventually told us, "Oh, you should put a formal complaint into the GMC," which Mike Delaney has done, the new president, and we're awaiting a satisfactory response.
Yeah, yes, of course, we have discussed that ourselves, haven't we? And I've discussed it also with Mike Delaney. So that is a matter of concern. I've got sort of a three-part question here from the same person. One is about whether there's a need to further inform MPs and peers about the availability of this treatment. Whether any, well, I think perhaps you know the answer is whether any peer-reviewed papers have been produced in the UK on the subject. I suspect the answer to that is no, but I was going to ask myself whether the evidence you've just described is going to be written up in some way. So perhaps those two parts you could deal with.
Yeah, we will certainly write the story now. Getting it published, there's no way that a journal like the New England Journal of Medicine or the Lancet or the BMJ is going to publish a paper with a pro-life slant on it. The Lineker Quarterly have asked me to write a paper describing APR in the UK, and I think that'll probably be our best. And that has a ranking. It's not a high-ranking one, and it certainly wouldn't be rated by our opponents in this area, but we probably will write a paper for the Lineker. Just on the parliamentarian side of things, I had a meeting with the chair of the All-Party Parliamentary Pro-Life Committee, Carla Lockhart, which is organised through Christian Concern. I had a very sympathetic meeting with her in December, and at that stage we didn't know how things were going to go, but she was going to write to NICE, and she was going to write to Charlie Massey from the GMC at the time. She probably doesn't need to write to Charlie Massey. It might be no harm though to write or to discuss it with NICE, because there's one issue. NICE in November brought out a statement supporting the use of progesterone for women at risk of recurrent miscarriage. And initially, their initial paper, and that's backed with evidence to support it. And NICE don't make statements without some evidence, but generally,
yes.
But it's backed. The initial paper said nothing about what we were doing about abortion pill reversal. However, NICE had invited submissions from interested parties, and it was when I looked up the consultations that took place, and BPAS, the British Society of Abortion Care Providers, and MSI all put in submissions pleading with NICE or requesting NICE to specifically mention that this use of progesterone did not include, or must not, or should not include use after mifepristone, because there was no evidence base for it. So NICE acquiesced, and they, in the small print, they on their eventual document, not on the initial draft one, they said this does not apply to progesterone use as an abortion reversal procedure after mifepristone has been taken, because we are not aware of any evidence to support this. Now, the reason I'm not aware is that they haven't looked for any evidence. It was also interesting that MSI in their submission, in an effort to persuade NICE, actually lied. They were dishonest, and they said, we know of several women who have had a poor experience at the hands of doctors providing abortion pill reversal in this country. And that is a lie. There's no, or at least NICE should have challenged them and should have said, okay, tell us about these women who've had this poor experience, and what evidence do you have? Because I can guarantee they do not have any evidence. So Carl Lockhart was going to write to NICE purely on that question, challenging them to find out what evidence there is that, first of all, that APR is not effective, and secondly, the evidence that MSI claim they have, that women have suffered or have had, in their words, a poor experience with this.
Yes. Well, thank you very much, Dermot. Can I just put a two-part question? First part is, can you now continue to prescribe, and can any other doctor prescribe progesterone now? That's the first part.
Yeah.
The second part is, did your legal team find that the GMC departed from its usual process in your case, thinking particularly about the early meetings which didn't deal with statements of fact? As far as you know, is that a regular process, or was it unusual that they took that approach?
Yeah, on the first question, yes, any doctor, in fact, any doctor, I was the only doctor specifically ordered not to prescribe it. So any doctor could, even over the last year, have prescribed it if they had been willing to do so. I didn't expect that many would come forward. I am aware of one doctor, mind you, in a particular part of the United Kingdom who has had a number of women come to him, and he has provided abortion pill reversal to them. But yes, any doctor can. And that's both of the expert witnesses agreed that you do not have to be an obstetrician gynecologist. They saw absolutely no reason why a cardiologist with a reasonable knowledge of the subject, and I had demonstrated by my reading, by my attending meetings, by my discussions with people, and by the way I'd answered all of the questions, that I had, both of them accepted that I was, could be considered expert enough in this area. They also pointed out that the provision of the Abortion Act states that for the abortion only needs to be recommended by 2 medical practitioners. It doesn't say they have to be gynecologists, obstetricians, just 2 registered medical practitioners who agree that abortion is necessary under whatever grounds they do so. And the other aspect, the other point that I highlighted in my response is that the vast 98% of all abortions every year, year after year, are performed on the basis of ground C. And then, because we know this, because the doctors do not have to tick the box. And we know that in all of those cases, because in the opinion of the doctor, continuing the pregnancy will harm the mental health of the mother or the woman more than terminating the pregnancy by abortion. And there's absolutely no evidence anywhere in the world to suggest that abortion is necessary to help a woman's mental health. In fact, it's the other way around, that there is evidence that women with pre-existing mental health disorders will deteriorate much more by having an abortion than if they had continued with the pregnancy. So, and none of the people making these decisions, none of them, or very, very few of them, if any at all, will have psychiatric training or psychological training, psychological counselling behind. And yet they're making these decisions based on the mental health of the woman suffering if they continue with the pregnancy. On the second question, sorry, what was the second part?
Whether the GMC procedure was their regular procedure or unusual in any way?
We don't know, because I said the Christian Legal Centre were not used to dealing with the GMC. I think it was their first encounter, and they were dismayed. They were dismayed by the way that the hearings took place. The first one you could understand, you could look on it as a pre-trial assessment. Do we need to look into this in greater detail? Although to leave it for 18 months is a bit of a stretch. Usually after your pre-trial hearing, you go to trial pretty soon afterwards. But certainly the review, they were astonished that an early review was called on the basis that new evidence had been gathered and presented, and yet we were told at the start that the evidence is not going to be looked at. We're purely this is not establishing the veracity or the how anything really about the evidence at all. It was just about the allegations, and do we need to maintain the conditions. So whether it's different from the normal GMC hearings, we don't know. We think it is. We think it probably is, because we think that the GMC were, for whatever reason, were beholden to or under pressure from these ideological forces who wanted them to behave in a certain way. The aim was to basically close down APR in this country, and it almost worked. Ironically, it has led to a greater awareness of it. There are the public and the medical profession now know much more about APR than we could have dreamed of a year ago.
Yeah, indeed. Well, look, Dermot, thank you for those answers. I think given that it's almost 9, I do want to finish soon. I'm going to end by offering Eileen the floor. Eileen, I can allow you to talk or make you a panelist. I'm going to click allow you to talk. Can you now speak?
Sure.
Would you like to say a few words, Eileen, about what you've heard tonight, or add any thoughts of your own?
Yeah, no. Our cases were very similar. I just want to give you the good news that I had an email from the GMC today to say that the 2 senior case examiners have looked at the expert witness report and the case will be closed.
Oh, excellent news.
Hot off the press.
Marvelous.
So that's a nice short, I mean, yeah, our cases were similar. I think Dermot and I, shortly after we started doing this work, we did a small presentation at a 40 Days for Life, March for Life, actually, virtual meeting in June 2020, or 21, getting mixed up. No, June 2020, yeah. And I think from that point on, I think pro-choice people were watching us and they were trying to find a way to trip us up. And I think Safe Action Abortion Fund found out about us, and I think they told the RCOG and they told Open Democracy, and they were trying to find one way to trip both of us up. MSI got a hold of Dermot really because of those 2 cases they tried to get him for. I must have been dodging the bullets, but that's how they set. I don't know if they were setting me up in particular, but they did a sting operation on Ash Wednesday throughout Europe and actually Canada as well. I hadn't realised I'd been stung, although I did think it was a bit of an unusual consultation. The girl was asking a lot of questions and was very unlike any other consultation I'd had. Normally patients are quite distressed and they're very keen to get help, but she was asking a lot of questions. Where did I work? How come this isn't on the NHS? What was the risk of me bleeding? She just wasn't sure. And she would give very monosyllabic answers. And I just kept filling in the space, like an awkward silence. I would fill it in with more and more information. Anyway, that was only evidence that the GMC had on me. And my lawyers kind of took a different look. I don't think they can believe that it's been dropped, because I was never told that was a possibility it could be dropped. I was told the next thing that would happen would be my note 7. The note 7 means that you have seriously fallen below expected standards and there are definite allegations against you. I wasn't told that that might not happen. So I think they are completely gobsmacked. I think this was a case that nobody wanted to touch, and that's why it did take so long, as Dermot referred to earlier. They couldn't get a GMC expert on list. They had to go off list, and they got this guy who's an obstetrician gynecologist on the 5th of November last year. And yep, both the GMC expert witness reports for Dermot and myself were handed into GMC on the 15th of February, but it was only in the last 2 weeks when I knew Dermot's outcome, and I told my lawyers that, they said, well, that's a really positive development, and we still hadn't heard anything. They started to put a little bit of pressure on the GMC to say, she's got this hanging over her, and then they started to move a bit. So it's happened quite quickly in the last couple of weeks, but as I say, just today got the news that, so that then gets presented to the IOT, and their reasoning for dropping it will be explained to me. And so, yep, it's all great, really. So it's really, how do we move forward from this? And I think there's a lot of lessons that we have learned through this process to make it watertight, really, for going forward and for educating other doctors who want to get involved in this. And it's really been very educational. The other thing, we were talking about publication. There's a doctor out in Australia who's running a trial called the Pamper trial, and that's an ethically approved through a university in Australia. I can't remember exactly where, but they're trying to recruit patients for this and they want to get it published, but they're also trying to get our study published. So it's going through the ethics approval at the moment, that we can use de-identified data So we hope to get our study published. I think that would be great. And then going forward, I think any patient we do help in the future, we'd hope to get it, invite them into a study as well, so that nobody can do this to anybody else again in the future, that we are watertight and nobody will have to fear be reported to the GMC, because obviously that'll be a big stumbling block for others wanting to get involved and getting insurance and stuff like that organised. So yeah.
Good. Well, thank you so much, Eileen. And I'm sure I speak for everybody on this call to say that I'm absolutely delighted that that today was the day you also got that good news.
Yeah, thank you.
Well, thank you both. And I must say, I'm sure we all admire your courage in standing up and taking the risk involved in offering the treatment that you did, that resulted in lives being saved, and for bearing the brunt of the reaction to it.
Can I just answer? I see there's one question here from Wojciech Rakovic, who I just want to clarify.
If you could quite briefly then.
Yeah, with respect to publishing 32 successful treatments out of 91, it's true that 91, we believe 91 commenced treatment, but a lot of those stopped it within the first day or two. In fact, some of them only took one tablet. So those who actually continued the treatment was about 67. So 32 out of 67 brings it to 48%. So I think he just misunderstood the numbers who actually continued with the treatment. So a lot of those who started treatment stopped it within 1 or 2 doses or within 1 or 2 days.
Thank you very much for clarifying. Well, that's it for this evening. Thank you, everybody who stayed with us to the end. We, the Catholic Union, will keep in touch with I hope Dermot and Eileen, we can keep in touch with you about how things develop from here. Now that your cases are over, the general issue remains an important one. And I hope we can work with the CMA to take this forward. Thanks again. There'll be more events from the Catholic Union. If you're not familiar with us, please look at our website, catholicunion.org.uk. Please consider joining us if you're not already a member. Thank you very much for coming, and I wish you all a good night. Thanks again.
Thank you.
Thank you. Thank you.
Bye-bye.
Bye.
Bye-bye.
Thanks, Eileen.
Thanks. Cheers. Bye.